Ready? Testing. Ooh, that's loud. Good afternoon. Welcome to HIS, Hospice Item Set Training. And, excuse me, thank you for attending. We did expect a few more people in the audience, so we'll just try to accommodate as people come in. But thank you for making the effort to get here today. We really appreciate it. I'd like to introduce or at least acknowledge some people in the audience. We do have some central office people who are associated with the hospice item set, and they're in the back. And I'd like to just point out Robin Dow, right there, she just curtsied. Her manager, Mary Pratt, and we have another associate that's working with us, and that's Roxanne Dupre-Frank, waving her hand there. And they're all part of the quality measures area here at CMS. My name is Kim Roach, and I also work with hospice regulations here at CMS, and I'll be presenting first up today. We probably also have some regional office people who are watching by way of live streaming, and we most likely have some state surveyors who are attending as well. The other people that I'd like to acknowledge are some contractors from RTI who have been very instrumental in the quality measure development and the hospice item set. And I'd like to mention their names to you today. Renee Sullender, Sarah Selenich, Alexis Kirk, Shula Bernard, Franzi Rakowski, and tomorrow, Laura Hansen will be here. She's from the University of North Carolina, and she did a lot of work on the quality measures. So I'd like to do a little housekeeping with you right now. If you would take a look at the exits, just in case there would be an emergency. We don't have a fire drill planned, but if there's anything that might happen that you would have to leave the building, look for your exits. And Robin Dow is the leader in charge of getting people out to Area 3 in the parking lot if we have to go that route, okay? And I would advise you to take everything with you if we do have to leave. We're not anticipating anything, but just in case. If you could put your cells on mute, that would be great. We're planning a break this afternoon about 20 of 3, and there is a coffee shop downstairs, and that'll be open till about 4, so you should be fine with that. So if you need to go to the coffee shop, you would go back out to where the guards are, take a right and go down the steps, and you'll find the coffee shop, okay? If you need to use the restrooms, they're, again, right out the door to the left and down the hall to the left. Please make sure you keep your visitor sticker on while you're here. And if you get lost, just look for a CMS employee and ask them to bring you back to the auditorium, okay? If anybody has any general housekeeping questions, you can go back out the doors you came in right here in this room, and Israel is at the desk and he'll be glad to help you out with that. If you want to connect to the guest wireless services, there's an easel in the back with some very detailed instructions, and it takes a little bit of effort, but if you're very careful and don't miss any of the steps, you should be able to connect, okay? So we are live streaming right now, and at some point, probably by the end of the month, the presentations from today and tomorrow will go up for viewing on YouTube. So just wanted to let you know about that if you don't catch something today or you want to watch or listen again, this will be available. And the information about when and how to access the presentations will be given to you in the usual manner, probably on the Open Door Forum, if it happens after the Open Door Forum, which is scheduled for March 5th. You will see information about the presentations being posted on the Hospice QRP site. There'll be some e-news blasts on that, so on and so forth. If you have a question, you can always send a question into the help desk, but we will get the word out to you on that. Okay, so I think that's all the housekeeping information that I wanted to go over with you at this point. So today's day one of 2-day series, and just so that we're all aware, today's Tuesday, February 4th. This is being recorded, that's why I want to give the date. So this is sort of a snapshot in time of what's happening as of February 4th. So today we'll have a very small background on the HQRP initiative. We'll go over Section A, Administrative Information, Section I, Active Diagnosis, Section Z, which is Record Administration or Administrative. Then we'll have a Q&A for Sections A, I, and Z. That Q&A section will happen after the break, okay? And then we'll wrap up the day with dyspnea, Section J, and we'll just see how the timing goes. We may have time for more questions at the end. It just depends. So that's the overview for today. Now, as I mentioned, the presentation is being live streamed and recorded, so we will not be taking questions directly from the audience today. What we would like for the people to do that are here in person is, if you have questions, please write them on the index cards, which are being passed out now by Alexis and Renee. If you have any questions, if you would write your question down, your email address, if there's a specific area in the manual that you're referring to, and or if there's a specific slide, write that slide number down. The more info you can put on there, the better, and we'll get the answer to you. And we're doing that just so that we can maintain accuracy and consistency, rather than shouting out an answer. We want to make sure that we're researching and giving you the correct answer. Now, for the people that are viewing this on live stream, please wait till after the questions and answer session is completed. And if your question wasn't addressed, then we'll ask you to submit your questions. So you can see on the slide here the address for the Quality Help Desk, for the questions that need to be submitted for those that are watching by way of live streaming. And it would help if you put HIS training in the subject line. So again, if your question was not asked, for the live streaming participants, please email the questions after the Q&A session. And for those in the audience, if we get a couple questions that are similar, you may not hear your question specifically, but we'll sort of group them together and answer them as appropriate. So you may not hear your question word for word, but we'll capture the concept. Okay. So now let's talk about the background of the Hospice Quality Reporting Program. And what the content that I'm going to be using is from Chapter 1 of the Hospice Item Set Manual. Section 3004 of the ACA establishes the Quality Reporting Program. And Section 3004 establishes or authorizes the Secretary of the Department of Health and Human Services to establish a quality reporting program for hospices. And everybody in this room knows that there is a program for quality reporting for hospices. And the AC specifies that for fiscal year 2014 and each subsequent fiscal year, hospice programs shall submit to the Secretary data on quality measures. And it also describes the measure endorsement requirements for any measures specified by the Secretary. The Centers for Medicare and Medicaid Services implemented the Hospice Quality Reporting Program in fiscal year 2012 by way of the final rule, which is dated August 4th, 2011. And the hospice item set, as part of the HQRP, you can find all of that information in the final rule, which is published in the Federal Register in volume 78. And the reason why we're here, in a nutshell, is that hospices will submit an HIS admission and an HIS discharge for each patient admitted on or after July 1st, 2014. Now, you'll notice the third bullet here says that the Office of Management and Budget, otherwise known as OMB, still has not approved the HIS. That approval is pending. You know, it takes a little bit of red tape, a little bit of time, but we've been in close contact with our contacts there, and we're anticipating that we should get the good word one of these days. So for the fiscal year 2016 reporting cycle, as I said, data collection begins July 1st, and the payment impact is for fiscal year 2016. And just in case you don't know that in the audience, fiscal year 2016 begins October 1, 2015. Okay, so for the HIS, who does the HIS apply to? It applies to all Medicare certified hospices. And right now we have about 3,700 Medicare certified hospices. So this would include all of those hospices, including those that are deemed by the accrediting organizations with deeming authority. Every one of the hospices must submit the HIS data. And detailed information about the submission process and the KEYS ASAP system will be provided in May during the technical training, and we'll talk a little bit more about that later on. But you'll get more details about the actual nuts and bolts of submitting in the May technical training, which will not be in person. Some people are wondering about the reporting eligibility for new Medicare certified hospices, and that information will be communicated through rulemaking, otherwise known as the Notice of Proposed Rulemaking, the final rule. And we're looking for the Notice of Proposed Rulemaking to come out the end of April, the beginning of May. But it's important to note that any hospice who is on the track to go through their initial survey for certification, they need to meet all of the quality requirements in anticipation of their initial survey, after they have their initial survey, while they're waiting to get their certification number. So all the quality reporting requirements must be met. And data is collected and submitted on all patient admissions. So what does this mean? This means that no matter the payer source, Medicare, Medicaid, private payers, all payer sources, patients of any age, that would be pediatric patients and adult patients, no matter where the patient receives the services, could be the Little Red Brick House, a nursing home, an assisted living facility, or a freestanding hospice. So data is collected and submitted on all of those patient admissions. Whether the patient was a transfer from another hospice, again, the admission data must be submitted for that patient. And even if that patient had previously received hospice services and revoked the benefit and is now with another provider, those patients need to have the HIS submitted for an admission and for a discharge. And that data will be submitted electronically to the HIS ASAP system. Now, the quality measures are specified for patients 18 years and older, so there are some exclusions, and you can find those exclusions in Appendix C of the Hospice Item Set Manual. That's Appendix C, and you'll see the information about exclusions. In addition, the measures that will be implemented are endorsed with a 7-day length of stay exclusion. And that's for the 6 NQF endorsed measures and the other modified measure. And you'll hear more about that today. And as you're looking at the slide, you'll see on the bottom right-hand side, it says HIS Manual, page 1 to 2. That's the reference to where you'll find the actual content of the subjects that we're talking about today. And these PowerPoint slides are located on the Hospice Quality Reporting website under HIS. Okay, so the item set. The HIS is an item set. It's a standardized tool for abstracting data. The HIS is a standardized set of items intended to capture patient-level data that can be used to calculate the 6 NQF endorsed measures and the 1 modified NQF quality measure. And these were selected by CMS for implementation into the Hospice Quality Reporting Program. The HIS is not a patient assessment instrument, and it does not replace a thorough and ongoing assessment of the patient as required in the COPs. And it doesn't replace standard clinical practice. It's up to your agency to continue to practice as you have been, thinking about quality care and services that you're providing to the patient. Eventually, when you get quality measurement data, you'll be able to look at that data and look at your practices and make a determination if you're, doing the best that you can for your patient population. The HIS is not administered directly to the patient and or the family. Hospices will complete the hospice item set by reviewing the clinical documentation in the record. Again, the HIS only captures items needed to calculate the quality measures. Because the hospice item set is not a patient assessment, there are no embedded patient screening or assessment tools within the item set. Hospice clinicians are free to use their preferred patient screening and assessment tools, selecting the best one for their particular patient population. And guidance is provided in the manual as to how to record, or how to actually look in your clinical record and abstract the data and record that data on the HIS. And you're going to learn more about that today and tomorrow. There's some examples that some of the other presenters will be using. So the HIS may be completed by any hospice staff member. The person completing the HIS will be reviewing the hospice clinical record and using documentation in the record to complete the HIS. The primary source of information for completing the HIS is data collected through clinical care processes that have been documented in the hospice clinical record. So this means, in general, sources outside of the clinical record are not to be used, although you'll see today there are some instances where they can be. For example, in the administrative section, you might need to look at claims and billing for some of the information they ask for, like the NPI, so on and so forth. In the section F, as in Frank, for preferences, the abstractor may need to look at or review the POLST form, or the MOLST form, whatever your state may term that, physician order for life-sustaining treatment, or any equivalent forms. So basically, what the way most people have practiced their whole clinical life is if a particular care process is not documented, then it didn't occur. So that clinical record will be very, very important for abstraction purposes. So, you'll need to make sure that skip patterns are followed and that an HIS is completed even if a patient revokes the benefit or is discharged from the hospice before all the care processes have occurred. This is really a snapshot in time as to how your agency is practicing and delivering care and services. So for implementation, just one word to you. If you have not downloaded the HIS manual, it's not really too big, okay? Please go to the Hospice QRP site, and over on the left you'll see HIS, and you've got this manual that is divided up into 3 chapters and some appendices. Very easy to read, and it will be your source of information to fill out the HIS assessment, the HIS forms correctly. So if you have not downloaded the HIS manual, please do so. Also in that area is a 1-page HIS fact sheet, which is very important. That could be a job aid that you might want to pass out to various clinicians, various members in your hospice. There's a lot of good information on that site. So for implementation, make sure you read the HIS manual, and review the HIS admission and the HIS-Discharge forms, which are in the appendix. Take a look at those. You may want to match or crosswalk what's in the forms against what you are currently using in your assessment forms. You can map that out and make sure you're capturing everything that you need to capture. Or it's allowable that you add the HIS items to your existing forms. This would allow for a one-to-one abstraction. Okay. So there is some tracking that will be required by hospice agencies because there are some conventions or some rules that have to be followed about timing. So I'm going to talk about completion and submission deadlines. For completion, the HIS admission records, the completion date should be no later than the admission date plus 14 calendar days. The completion date can be equal to the admission date or no greater than 14 days later. However, it cannot be prior to the admission date. Now for the discharge completion, the completion date should be no later than the discharge date plus 7 calendar days. The completion date for discharge can be equal to the discharge date or no greater than 7 days later. However, it cannot be prior to the discharge date. And all of this information is in the HIS manual for you. For the submission deadlines, for the admission record, the submission should be no later than the admission date plus 30 calendar days. The submission date can be equal to the admission date or no greater than 30 days later, but again, it cannot be prior to the admission date. For the HIS discharge records, the submission date should be no later than the discharge date plus 30 calendar days. Again, the same logic follows. The completion date can be equal to the discharge date or no greater than 30 days later. However, it cannot be a date prior to the discharge date. So the admission date, that is actually item A 220. And the admission date is the date the patient and family chooses hospice to begin. For Medicare patients, it is the same as the effective date of the hospice benefit election, which may be the first day of hospice care or a later date, but no earlier than the date of the election statement. For the discharge date, that's A270, and that's the date a patient leaves the hospice. If the patient expires, it's the date of death. For live discharges, if the patient revoked the benefit, it's the day of revocation or the date the hospice discharged the patient. The completion date is Z500B, and the completion date is defined as the date all required information has been collected and recorded, and staff have signed and dated that the record is complete. This date should represent when the hospice item set has been complete and verified by an authorized individual who is authorized to make that statement. It's an attestation. This individual signs and dates. Z500. Okay, so then we come to the submission date, and that's defined as the date on which the completed record is submitted to the KEYS ASAP system. Now, HIS admission and discharge records could be completed and submitted on the same day if the situation supports that happening. You may have a patient under care for 12 hours. No, you're probably not going to have all of the care processes taken care of, but you need to record what you did do for that patient and the circumstances. So here's a sample calendar, and this might be a nice calendar to use for teaching purposes in your agency if that's your role. You can see here the way we've plotted this out is the patient was admitted on July 1st. So the record had to be completed by 14 days later, which would be the 15th. Okay, so you see the 1st and the 15th. The record needs to be submitted 30 days after the admission, and that would put us no later than the 31st. Okay, now for the yellow boxes, this shows the patient discharge. The patient was discharged on the 12th, so the HIS discharge had to be completed by the 19th, and it needs to be submitted by 30 days after the discharge, which puts us at August 11th. So there will be some tracking involved. You'll need to figure out in your particular agency how to track this and make sure that you meet the submission deadlines. So for submission, as I said, the HIS admission record must be submitted before the discharge, except in very distinct circumstances. And the submission should occur to the CMS Quality Improvement Evaluation System, otherwise known as the KEYS system, and the ASAP system, which is really one system. It's just kind of spelled out here looking like it's two. And additional details about submission will be provided to you in May during the technical training. So this is a lot of information, a lot of record keeping. What are you going to do with this information? You want to treat this with the security that you use for all of your other records. It's recommended that you keep a copy of the HIS and any of the corrected versions that you may have. The signature page should be kept for potential future validation purposes. Your agency should most likely have policies that support the collection and the submission of the HIS and the maintenance of the records. So that's a lot of information, but remember, that's an overview, sort of to set the stage. And as we go through today and tomorrow afternoon, we'll get deeper into each question and give you examples about collection and actually ask you to do a little work together to help determine some answers. So at this time, if you have any questions about what I discussed, please feel free to write them on the index cards, or if you want to just write them on a big piece of paper, you can do that too, but make sure you put your identifying information on that. And some of the instructors from the back of the room will come down the aisle, I believe the center aisle, and pick up any questions. Okay, so I'd like to ask Sarah to come up. Where's Sarah? There she is. Okay. Sarah, would you like to take over? Thank you.
So thanks, Kim. So good afternoon. My name is Sarah Salinich. Kim just covered, as she said, the content in Chapter 1 of the manual. So before we get started on Chapter 2, for those of you, again, if you could pass your questions that you might have to the center aisles, and Alexis and Renee will come by and pick them up. And then, again, for those of you streaming the presentation, just wait until after the question and answer session this afternoon. And we will make sure, again, to put your email address on your cards, and we will send you an email response if we don't get to it in the Q&A session. So now we're going to turn to Chapter 2, and this starts on page 2-1 of the manual. Chapter 2 contains completion instructions for each item in the hospice item set. Before we go over these item-specific instructions, I'm going to take a moment to provide some high-level information on the sections of the item set and their relationship to the 7 quality measures. So as Kim mentioned, the hospice item set captures data from the hospice clinical record that can be used to calculate 7 quality measures, 6 that are National Quality Forum endorsed, and 1 that's a modification of an NQF endorsed measure. We'll talk about that modification in tomorrow's presentation. So as you can see from the table on slide 17, there are 6 sections in the hospice item set. 3 sections, sections A, I, and Z, contain administrative items that are primarily used for record matching and identification. The other 3 sections, sections F, J, and N contain care process items that capture if and when care processes took place. The data captured in these three sections are the main components that go into the quality measure calculations. Of course, data from the administrative sections, such as the date of admission, will also factor into the quality measure calculation. While we won't go over it now, additional details about the quality measures are presented in Appendix C of the manual. As Kim also mentioned, hospice providers will be required to submit 2 hospice item set records for each patient admission to hospice, an HIS admission record and an HIS discharge record. Slide 18 shows the sections for each. The HIS admission record contains administrative and care process items. The HIS discharge record contains a limited set of administrative items, including 2 discharge-specific items. So now we're ready to delve into the item-specific instructions. I will cover sections A, I, and Z, which contain administrative items. And then the other presenters will go over sections F, J, and N this afternoon and in tomorrow's presentation. And those contain care process items. So section A, administrative information, starts on page 2A-1 of the manual. As a reminder, we'll be referring to content in the manual. So the corresponding manual page numbers are in the bottom right corner of each slide, as you can see on this slide here. This is particularly important for section A, as we will not be proceeding through this section sequentially. Instead, for the presentation, we've grouped together items based on the types of information that they capture. You may also find it helpful to pull out the HIS admission and HIS discharge forms that are in Appendix D of the manual. Also, just a quick note about the layout of the manual. If you look at the manual, if you have it in front of you, the beginning of each section contains an overview of the items as well as a section rationale. For section A and the other administrative sections, each item is shown as it appears in the item set, and then it's followed by item-specific instructions and, in some cases, item-specific tips. So section A contains key information that uniquely identifies each patient, the hospice from which he or she receives services, as well as the reason for record. As Kim mentioned, hospices will submit their data electronically to CMS's HIS ASAP system. This information is needed to create records in the HIS ASAP system. And again, additional details on submission will be provided during the technical training in May. So turning to the items, there are 2 items that indicate the record type or purpose, A0050 and A0250. Item A0050, type of record, appears on page 2A-1 of your manual. For this item, you will indicate whether an HIS record is a new record to be added to the HIS ASAP system, or if a previously submitted and accepted HIS record requires modification or inactivation. We will only briefly discuss A0050 here, as more detailed information will be presented during the technical training. What you need to know is that in most cases, you will select code 1, add new record. You select code 1 for a new HIS record that has not been previously submitted and accepted into KEYS ASAP system. So if there is an existing record for the same patient, same hospice, with the same reason for record and event dates, then the record you are trying to submit would be a duplicate. Therefore, it would be rejected by the KEYS ASAP system. A fatal error will be reported to you on the final validation report. You don't need to turn there now, but further details on the final validation report can be found in Chapter 3. Selecting Code 2, Modify Existing Record, creates a modification request and is used when an HIS record has been previously submitted and accepted into the KEYS ASAP system, but the record contains errors. The types of errors that may be corrected in a modification request include errors in transcription, data entry, software product, item completion, or other errors requiring correction. Errors in most items on a HIS record can be corrected with a modification request, but with some exceptions. Further details on modification requests can be found in Chapter 3 as well. Selecting Code 3, Inactivate Existing Record, creates an inactivation request and is used when an HIS record has been previously submitted and accepted into the KEYS ASAP system, but the corresponding event did not occur. For example, a HIS-Discharge record was submitted, but the patient was not actually discharged. Or particular item values, such as key patient identifiers, are inaccurate. And again, further details can be found in Chapter 3. So the other item on slide 22, AO250, Reason for Record, appears on page 2A-4 of the manual. This item collects the reason for record, either admission or discharge. You would select code 01 for admission record or code 09 for a discharge record. On slide 23, we have grouped together identification numbers. The first are on page 2A-2 of your manual, and they make up item AO100. AO100 collects facility provider numbers, including the National Provider Identifier, NPI, which is a unique federal number that identifies providers of healthcare services, and the CMS certification number, CCN, also known as the Medicare Provider Number, and this is a 6-digit number. You will notice that the item set actually has 12 boxes, and the last 6 which are grayed out, but you won't use those. You will just use the white boxes. If you turn to page 2A-6 of your manual, you will see item AO600, which collects the patient's Social Security and Medicare numbers. AO600, the Social Security number, may be left blank if the patient does not have a Social Security number. The same is true of AO600B, the Medicare number. Although, if the patient does not have a Medicare number, a Railroad Retirement Board number may be substituted. Item AO700, Medicaid number, appears on the next page of the manual, 2A-7. You'd enter the Medicaid number if the patient is a Medicaid recipient, unless the number is pending, in which case you enter a plus sign. You do this even if Medicaid is a secondary payer. If the patient is not a Medicaid recipient, you'd enter an N. Section A contains several other patient information items, as we see here on slide 24. Item AO500, legal name of patient, appears on page 2A-5 of the manual. This should be the patient's name as it appears on their Medicare card, or if the patient is not enrolled in the Medicare program, it is the patient's name as it appears on a Medicaid card or other government-issued document. It is very important to check the spelling of the patient's name each time an HIS record is submitted, since typos could lead to duplicate records for patients in the KEYS ASAP system. The rest of the items on the slide begin on page 2A-8 of the manual. For AO800 gender, you would select code 1 if the patient is male, and code 2 if the patient is female. For AO900 birth date, you would enter the patient's birth date using the format month, month, day, day, year, 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 year. If the month or day contain only a single digit, you would enter a 0 in the first box of the month or day. For example, November 1st, 1930 would be entered as 11/01/1930. If you don't have the patient's full birth date, for example, let's say you only know the birth year, you would enter the year in the last 4 boxes, the year boxes, and leave the month and day boxes blank. For A1000, race or ethnicity, you check the boxes that correspond to the races or ethnic categories that the patient uses to identify him or herself, or that the patient's family, significant other, guardian, or legally authorized representative uses to identify the patient. Observer identification can be used if the patient is unable to respond and no family member, significant other, guardian, or legally authorized representative is available. On slide 25, we have a couple of date items. AO220, admission date, is covered on page 2A-4 of the manual. The admission date is the date the patient or family chooses for hospice to begin. For Medicare patients, it is the same as the effective date of the hospice benefit election, which may be the first day of hospice care or a later date, but may be no earlier than the date of the election statement. A day begins at 12 a.m. and ends at 11:59 p.m. Item AO245, date initial nursing assessment initiated, is on that same page of the manual. This is the date of the first clinical screening and assessment of symptom needs used by the hospice organization to determine the plan of care. Section A contains 2 service site items. First, AO205, site of service at admission, can be found on page 2A-2 of the manual. Response options for this item are structured to match sites of service found on Medicare claims. Since the site of service must be identified on Medicare claims for the initial level of care billed, identifying site of service the same way when completing the HIS item can reduce administrative burden for the hospice. Item A1802, admitted from, is on page 2A-9. For this item, you should enter the code that best describes where the patient was immediately preceding admission. The term admitted from does not necessarily mean that the patient left the facility to be admitted to hospice. The location immediately before admission may be the same as immediately after. For example, a patient may be residing in a long-term care facility and remain there during and after hospice admission. On slide 27, we have two items that are only found on the HIS-Discharge record and not on the HIS-Admission record. In other words, you will only complete these items if AO 250, reason for record, is equal to 09, discharge. Item AO 270, discharge date, is on page 2A-5 of the manual. If the patient expired, the date of death is the discharge date. For live discharges, the discharge date is the date the patient revoked the hospice benefit or the date the hospice discharged the patient. Item A2115, reason for discharge, is on page 2A-11 of the manual. For this item, you should review the clinical record, including the discharge plan and discharge order, for documentation of discharge reason, and then select the appropriate code. So that concludes section A. Please, if you have any questions, take a moment to write them out and then pass them to the ends of the aisles. Again, remember to put your email addresses on your index card along with your question. And then for those streaming the presentation, please wait to submit your questions until after the Q&A session. I believe Renee and Alexis are going to come around to collect if you have any questions. Okay. So we'll now take a quick look at section I, active diagnoses, which is on page 2I-1. There is only one item in section I, IO 100, which is principal diagnosis. The rationale for this section is that disease processes can impact service delivery. I want to take a moment to emphasize that the hospice item set is intended for use in quality reporting, and it does not imply acceptability for payment purposes. The principal diagnosis is defined as the condition established after study to be chiefly responsible for the patient's admission. For hospice patients, this is the diagnosis most contributory to the patient having a life expectancy of 6 months or less if the illness runs its normal course. For this item, you would select code 01, cancer, if the patient's principal diagnosis is cancer, and that's including leukemia. You would select code 02, dementia Alzheimer's, if the patient's principal diagnosis is dementia, including Alzheimer's disease, frontotemporal dementia, Pick's disease, other frontotemporal dementia, senile degeneration of the brain, and dementia with Lewy bodies. Note that some dementia codes have ICD-9 and ICD-10 manifestation or etiology or sequencing conventions. Ensure that coding guidelines have been met for reporting principal diagnosis. Cancer and dementia Alzheimer's were selected as response options because they are the most common principal diagnoses among hospice patients. For all other principal diagnoses, you should select code 99, none of the above. So we'll now take a look at section Z, record administration. And then after going through section Z, we'll take a break. And I know we're running a bit ahead of the agenda, but this will give us maybe an opportunity for more question and answer time, and some of our later sessions may take a little bit longer. So there are two items in Section Z, which begin on page 2Z-1 of the manual. I'll give you all an opportunity to flip there. So these items are ZO400, signatures of persons completing the record, and ZO500, signature of persons verifying record completion. The signatures are for use and retention by the hospice. They indicate attestation that the abstracted information in the HIS record is complete and accurately reflects patient information. However, the signatures are not transmitted to CMS. The only thing in this section that is transmitted to CMS through the KEYS ASAP system is ZO500B, completion date. So in practical terms, this section allows hospices to look back and see who is responsible for completing which sections. And by completing, we mean abstracting data from the clinical record and filling in the record, and who verified that the HIS record was complete. Section Z should be retained in accordance with the hospice's policies regarding patient information. Staff completing the HIS record may or may not be the clinician who completed the care processes. In other words, the person who actually assessed the patient for pain may or may not be the person who abstracts the pain assessment data for that portion of the HIS record. So let's look at the items in this section. Looking at item ZO400, you'll see that there is a place for more than one person to write their signature, title, section that they completed, and the date that they completed that section. All staff who complete any part of the HIS record will enter this information, and these signatures may be electronic. A few additional notes. So let's say that an individual completes multiple sections of the HIS record. Then that individual can sign once in ZO400 and then indicate which sections they completed in that section space of ZO400. One or more staff members can complete items within the same section of the HIS record. When filling in the information for ZO400, any staff member who's completed a portion of a section should identify which item or items he or she completed within that section. Staff members should enter the date they actually completed their section or portion of a section, even if they are signing ZO400 at a later date. So here's a quick example. Let's say that James completed Section A on July 15th. However, he doesn't go to sign Section Z until July 17th. What date should he enter for ZO400? Hopefully you're all thinking July 15th, because that's the date he actually completed his section. Staff members should read the attestation statement carefully. Persons signing ZO400 are certifying that the information in the HIS record, to the best of his or her knowledge, accurately reflects documentation in the patient's clinical record. So let's look at ZO500. I'd like to note quickly that there's a slight error in the manual. In the manual, it says that item ZO500 is used to document the individual responsible for ensuring the HIS is complete and submitted in a timely manner. However, this is inaccurate. It shouldn't say submitted. ZO500 is used to document just the completion of the HIS record. So ZO500A is the signature of the person who goes through and verifies that all of the items in the HIS record have been completed. Just one person should be responsible for this. However, this person is only verifying record completion. They're not certifying the accuracy of items that other staff members filled out. ZO500B is the date that the person verifies that all of the items have been completed and is the effective HIS record completion date. What this means is that hospice staff may have completed all of the sections by August 1st, but if Mary, for example, doesn't review the record for completion and sign ZO500A until August 2nd, she would enter August 2nd for ZO500B. Again, ZO500B is the only thing in this section that gets transmitted to CMS through the KEYS ASAP system. So that concludes section Z. And then, Kim, is there anything else that we need to say before we, okay. So we'll now take a 30-minute break. So it looks like you should return by 2:05. And then we will begin with a question and answer session on Chapter 1, Chapter 2, Section A, I, and Z. And then again, for those present in the room, you can pass any questions to the ends of the row, and Alexis and Renee will collect them, or you can bring them to the back table. And then again, put your email address on your index card with your question. It will also help if you can include the slide number, section, and item number. And then again, for those streaming, please wait to submit your questions to the help desk until after the Q&A session. All right, great. See you in 30 minutes.
Ready?
Nope. Oh, there we go. Can you hear me now? Yeah, okay, thanks. All right, Francie and I will answer some of the questions that we've received. We do not have answers to all the questions. Like I said earlier, we want to make sure that we have accurate answers, so we need to do some research, but we will get those answers to you. So one of the questions, a hospice patient is admitted and discharged from one hospice, then admitted to another hospice. Which hospice has to complete the HIS? Well, the HIS admission and HIS discharge is completed on each patient admission, not each patient, so that the word is admission. This means that both hospices would be responsible for completing both the HIS admission and the HIS discharge within the required time frames, completion within 14 days for the admission, 7 days for the discharge, and then submission within 30 days for both. Another question, what do I do if I have a patient that is admitted, discharged, and then admitted to my hospice again? The answer is the HIS is completed for each patient admission. So you would complete the HIS admission, the HIS discharge, and then the HIS admission again when the patient is admitted a second time or a third time or a fourth time to your hospice. What if a patient is discharged before care processes are completed, say within 24 hours of an admission? You would still complete both the HIS admission and the HIS discharge for that patient. On the HIS admission care process items in sections J, F, and N, if the patient died before a care process was completed, this means that you would answer no to many of the items and follow the skip patterns. Although you will complete an HIS for all patient admissions regardless of the length of stay, 6 of the 7 quality measures are specified to only include patients with a length of stay of 7 or more days. 1617 is the only quality measure without the length of stay specification. Okay. I'm going to go to the next one. Do we submit an HIS for pediatric patients? Yes. Yes, you do submit HIS admission and discharge for all patient admissions, regardless of the payer source, the age, where the patient receives hospice services, whether the patient was a transfer, or whenever the patient previously revoked the benefit and was discharged. And although you need to complete and submit an HIS for patients of all ages, the quality measures are specified to only include patients 18 and older. So this means in the future, the quality measures calculations will exclude patients younger than 18 years of age unless the quality measure specifications change. So when you answer the question with the birth date, that will help with the exclusion. So that's why you need to be accurate on all of the questions so that the data can be used and calculated for the quality measurement. Okay, another question. What time frame should I be considering when completing the HIS? Is there a certain look-back period for the items in the hospice item set? And the answer is, in general, HIS items are intended to align with care processes conducted during the initial and comprehensive assessment periods. You can include a care process on the HIS as long as it was completed prior to the completion date, 14 days from admission for HIS admission, care process items. Please note, however, the completion time frame of 14 days is for HIS record completion purposes only. Care process timing for QM calculation purposes, for example, what counts as best practices, is outlined in Appendix C of the HIS manual. So please review Appendix C. There's some very informative information there. Is it the intention of CMS that the admission HIS questions are all answered by the RN on the initial nursing assessment that is required within 48 hours after the notice of election is signed? Do the questions need to be gathered during the comprehensive assessment? So please keep in mind, the HIS is not a patient assessment instrument and does not need to be completed by the RN during the initial nursing assessment. As for completion timeframes of the HIS, there are two separate collection timeframes to consider: the HIS admission within 14 days of admission date and complete an HIS discharge within 7 days of discharge. Again, you must also submit the HIS admission within 30 days of admission and submit the HIS discharge within 30 days of discharge. Now, this is the important answer here. Hospices have a wide variety of practices related to how patients are assessed upon admission and during the initial and comprehensive assessments. The Hospice Quality Reporting Program does not dictate that practice pattern. We are capturing each of your hospice's practice patterns patient by patient. Through feedback reports on each hospice's measure scores, your hospice will determine whether it needs to improve their practice patterns. Hospice organizations or vendors may choose to map or match items currently in the clinical records to items in the HIS. In completing this matching process, you may wish to add HIS items to medical records or patient assessment forms. Adding HIS items to the medical record does not make the HIS a patient assessment. It merely allows for a one-to-one abstraction from the medical record to the HIS. So CMS neither prohibits nor requires hospices to add HIS items to their patient assessment forms. That's your call as an agency. Do all questions on the HIS records need to be answered by only one clinician per client or per patient? As the HIS is not a patient assessment instrument, it does not need to be completed by just one clinician. The HIS records themselves may be completed by any staff member at the hospice. The staff member completing the HIS may or may not be the clinician that completed the care process. The HIS records do not have to be completed by a single staff member. Okay, another question. Will a submission be considered complete if most, but not all items or questions are entered? Is there a threshold for how complete a submission must be? Will a single incomplete submission result in the 2% reduction? Providers should complete all items in the HIS unless directed otherwise by skip patterns in the HIS. Providers should only leave an item in the HIS blank if a skip pattern directs them to skip over the item. Violation of skip patterns or unallowable responses and/or values for an item will result in record rejection or submission failure by the KEYS ASAP system. The draft technical specs include rules surrounding which items are required and will result in a fatal error if not completed. Providers should review the draft technical specs for the HIS for more information on allowable responses or values for an item and fatal and warning edits associated with that item. And the draft technical specs are posted on the cms.gov hospice website. Incomplete submissions are not possible. For example, a provider cannot successfully submit an HIS that contains a fatal error because that record would be rejected by the KEYS ASAP system. An incomplete record would need to be submitted. Okay, this question is what should I do if I miss the HIS completion or submission deadlines? Should I submit the HIS late? Well, number one, you should make every effort to complete it and submit on time. If you do miss a deadline, you should still submit the HIS data. There is mention in the technical specs that the admission date is the date the patient elected the hospice benefit. If the patient elects the hospice benefit while being treated by one hospice agency, but then is discharged by that hospice and is transferred or admitted to a new hospice agency, should the admission date reflect the date the patient elected the hospice benefit and not the date of the admission to the new agency? And the answer is that the second hospice agency should also collect and submit the HIS admission and the HIS discharge on the patient. The records completed and submitted will not contain the same information as the record from the first hospice agency. If the patient was actually discharged from the first hospice and left Medicare hospice, then he or she would have to re-elect the hospice benefit in order to re-enter hospice. In this case, the admission date of the second hospice would reflect the date of re-election of the hospice benefit. So if the patient simply transfers hospices and there was no break in the original election, then the hospice benefit periods remain intact. In this case, the admission date for the second hospice should reflect the date of admission to the second hospice agency. Okay. What do I do if the patient's information changes? Say they're not on an opioid when we first complete the HIS. At the end of the first week, the patient is in hospice care. But before the 14-day completion period is up, the they do start receiving an opioid. Do I have to go back and change the responses on the HIS? What if I've already submitted the record to CMS? For all items on the HIS, the hospice has until 14 days after admission to complete the items and to ensure that the HIS accurately reflects the information in the patient's clinical record. This means that items can be updated or corrected until the 14-day completion deadline for the hospice item set admission, and until the 7-day completion deadline for the hospice item set discharge. So this means if the hospice completed the HIS admission on day 6, but on day 12 the patient started an opioid and a bowel regime, the hospice can update the information on the HIS prior to the completion deadline. If you've already submitted the HIS admission on day 8, you would be able to submit a record modification. Additional information about how to handle record modifications will be presented in May during the technical training. Let's see. Here's a question. Are we allowed to submit several claims? We think that the person writing this question actually meant HIS records, so I'll reread that. are we allowed to submit several HIS records during the month on different days instead of current once a month billing for each, instead of current once a month billing for each client? Is there a limit to submitting HIS information? And the answer is, you can submit the HIS records one at a time or in groups. Details about submitting HIS records will be provided in May. Another question basically says, all payer sources, all patients regarding of length of stay are included? And the answer is yes. You will submit an HIS admission and discharge for all patient admissions. There are quality measure calculation exclusions that apply for the measures, and you can see the details about the exclusions in Appendix C. And you'll notice that most of the measures do have an exclusion for patients with a length of stay of less than 7 days and under age 18. But you still have to submit that information. That information will be pulled out when numbers are crunched for quality measurement purposes. Okay. What if someone comes on service with private insurance and then converts to Medicare during their time on hospice? Is the HIS resubmitted based on Medicare election date? The speaker said this cannot be done prior to the Medicare election date. And the answer is, it's likely that you will not have to resubmit the HIS record when a patient changes insurance, because the HIS is not used for payment. It's different than OASIS. We'll research this issue and get back to you if there's a different answer. Okay, what is the difference between completion deadline and submission deadline? Is the completion deadline when the recording of the data must be submitted and attestation signed? And the answer is, the completion deadline is the date the hospice has to complete all of the HIS data items, and the attestation is signed in Z0400. The record should be reviewed for completeness and sign and date Z0500. All of this has to happen by 14 days after the admission date for the HIS admission and 7 days after discharge for the HIS discharge record. The submission deadline is up to 30 days after admission and 30 days after discharge. This gives the hospice time to transmit the file. So there's a distinct difference between completion and submission. Can anyone at the hospice complete the HIS? For example, secretary, aide, contractor, or does it have to be a clinician? And the answer is that the HIS may be completed by any staff member. It does not have to be a clinician. And I would add here that your policy should support who's completing the HIS, and privacy and security measures must be in place.
Okay, and we'll move on to some questions that have come in about Section A, the administrative information. The first question is about the admission date, A0245. What do I do if a patient was admitted and then discharged from a previous hospice and then is admitted to ours? What would I put as the admission date? So this is a review of something Kim just touched on before. The admission date is the date that the patient elects to begin hospice services with your hospice. Regarding item A1802, what if I don't know exactly where the patient was? So this is the item about admitted from. So you would answer this item to the best of your knowledge. Remember that admitted from does not necessarily mean that the patient left a particular facility to be admitted to hospice. So for example, a patient may be residing in a long-term care facility and remain there after electing the hospice benefit. or the patient may have been residing at home and remains at home after electing the hospice benefit. So in those cases, the admitted from location is the same as the location where the patient currently resides. Regarding the facility provider numbers in A0100, do you want the numbers for the hospice admitting the patient or for the location where the patient is residing? And the answer is you would provide the NPI and the CCN numbers for the hospice that is admitting the patient. Another question is, why are there 12 boxes in the item set for the CCN? And the answer is that on the item set, there's 12 boxes, 6 of which you'll notice are grayed out. These additional boxes will allow for future growth in case CCNs get longer at some point in the future. For now, you only need to enter the digits in the 6 white boxes. Another question was, why does CMS need a plus or an N for pending Medicaid numbers? This item and the response options are standardized across item sets that are used in other reporting programs. And so those response options are standard as well. You would respond based on the information that you have available. Regarding item A0050, reason for record, is this used for each admission on the same patient? If admitted by one hospice, then transferred and admitted by my hospice, that is a new patient, correct? And yes, add a new record is to be used for each admission of the patient. Another question is, how do you identify that a patient has another payer source? And the answer to that is that the HIS does not require hospices to report whether or not the patient has another payer source. Do we enter a Medicaid number if Medicaid is only used for nursing home, room, and board? And you do enter a Medicaid number for all patients that have a Medicaid number. This information is being used for record identification in the KEYS ASAP system. It's not being used for billing or claims or other purposes. If they have a Medicaid number, you enter it in that HIS item. If a patient is under 18 years old, we must submit the HIS forms, but do we need to record data elements used in an NQF endorsed measure that excludes patients less than 18 years old? And yes, you will complete and submit an HIS admission and discharge for all patient admissions. You should not skip items in the HIS unless directed to do so by skip patterns in the HIS. For hospice to hospice transfers, should the date of the HIS match the date of the transfer or the date of the initial admission? And you would use the date that the patient is admitted to your hospice. Okay, we have a few questions about Section I. Okay, why does this section only collect information on these 3 categories of diagnoses? And this is because CMS did not want to add to provider burden to collect and report all patient diagnoses, since that information is already reported separately on claims for Medicare patients. But since the hospice item set is completed for all patient admissions, not only Medicare patients, we had to include an item that would give a broad identification of primary diagnosis to help with future measure development and potential risk adjustment in the future. Next question is, are the measures risk adjusted? And currently the measures that can be calculated using the hospice item set are specified without any risk adjustment, but future measure development may look at whether measures should be risk adjusted. And then we have some questions about Section Z. Who is supposed to sign Z0400? So Z0400 should be signed by any hospice staff member who abstracted information from the clinical record to complete the HIS, irrespective of who completed the actual care processes. So for example, say Nurse Jones completed the pain screening at the initial nursing assessment on July 2nd, and Ms. Miller, the Director of Quality Assurance and Compliance, fills out Section J, the pain section of the HIS, on the 12th of July. It would be Ms. Miller that then signs Z0400, not the Nurse Jones who originally did the actual patient assessment. And this gets back to the fact that the HIS is not an actual patient assessment. Can we use electronic signatures? And the answer is yes. Another question here. In Section A, some data items can be filled in electronically from the existing patient record. So for example, the legal name and the facility NPI, and some would have been filled in by the person actually seeing the patient. On the signature, so in Z0400 for the HIS, there is a section column. To what level of detail should that column be filled out? Meaning, we just identify the general section, or do we identify the section item number? And if it's the section number, how should those items that are auto-filled be signed off? Would an auditor looking at the signature page expect a signature against every single item number in the HIS? And the answer to this is that the hospice is required to ensure the accuracy of all the items on the HIS record, no matter how those items are entered or auto-populated in the HIS. And this means that the person responsible for reviewing any section should review all items in that section and put their signature in Z0400. All staff who complete any part of the HIS record should enter their signature, their title, the section or the portions of the sections that they completed, and the date. If more than one staff member completes items within the same section of the HIS record, then all of them should sign in Z0400 and identify which items he or she completed in the HIS within that section. And if there is a single individual that completes multiple sections of the HIS, that individual can just sign once in Z0400 and then list all of the sections they completed within the sections portions of Z0400. How long should we store the signature page? And the answer is that your hospice should establish a policy related to the retention of the signature page or following your existing policies. It looks like Section Z may be optional. Is this correct? And the answer is that all items in the hospice item set should be completed. In Section Z, item Z0400 is intended to serve as a record for the hospice in case there is an audit or other related questions in the future about who completed specific sections of the HIS. So for example, if you routinely see that there are errors in a section that is completed by a certain individual, then you would know with whom to address these errors by referring to who has signed in Z0400. Z0500 provides the actual completion date for the HIS and is the item that is, will be transmitted to CMS via the KEYS ASAP system. If the HIS elements, data elements are captured through an EMR system, and that system generates the electronic XML file bypassing the manual completion of the HIS, how is the data in Section Z recorded, since no one physically abstracted the data? And this is a very good question. Someone has to sign and date item Z0500, and electronic signatures are permitted. Z0400 completion is done by the staff completing the HIS record, not the person who documented the patient assessment data in the medical record, right? That's correct. The person completing the HIS may or may not be the person who actually assessed and documented the patient assessment. So this again goes back to the fact that the HIS is not a patient assessment, but rather a set of standardized items that can be used to calculate quality measures. And that completes the first question and answer session. And we're going to turn it over to Alexis Kirk. Thank you.
Hi everyone, good afternoon. Can you all hear me okay with the microphone? Okay, perfect. So as Francie said, my name is Alexis Kirk, and I'm going to be leading the last session in day 1 of the hospice item set training. So the good news is that in just over 2 hours, we've already covered the material in chapter 1 of your hospice item set manual, and we've already covered all of the administrative items in the hospice item set. So now we can really focus on what we want the meat of our presentation to be, which is going to be the care process items. As you may remember from earlier in the presentation, the hospice item set can be divided into 2 primary categories of items. There are the administrative items, which are found in sections A, I, and Z of the hospice item set, and there are the care process items, which are found in sections F, J, and N. So what we're going to focus on now are these care process items, but before we get into the specifics, I want to take a few minutes and just walk you through really what these care process items are and how they're structured. So as Sarah mentioned earlier, the administrative items are primarily used for patient identification and for record matching purposes. These administrative items aren't going to tell you about care processes that took place during a hospice patient's episode of care. Instead, it's the care process items that will capture if and when care processes took place and will form the basis of quality measure calculation. So, what is a care process item? In general, the care process items will direct providers to abstract data from the hospice clinical record, capturing information about care processes that took place during the initial or the comprehensive assessment period. And as you can see here on the slide, care process items specifically will capture data about whether or not a care process took place, when that care process took place, and in some instances, what the results of that care process were. The care process items are then used as the basis of quality measure calculation, and they will be used to calculate the 6 NQF endorsed measures and the 1 modified NQF endorsed measure as part of the hospice quality reporting program. And just to reiterate again, more information about each of the quality measures can be found in Appendix C of the Hospice Item Set Manual. I want to turn now to an example care process item just so we can kind of unpack the structure of the care process items. And you can see here on slide 39 that we have item J2030, which is the screening for shortness of breath item. And I'm going to go over this item in more detail in a few minutes to walk you through how you would complete it. But for right now, I just want to use it as an example to give you a high-level picture of how all of the care process items are structured. So as you can see here on the slide, this item has 3 parts. There are parts A, B, and C. Part A is what we call the gateway question. And the gateway question will always be a yes or no question and will tell you whether or not a care process took place. So here we're talking about item J2030, which is the screening for shortness of breath item. So the gateway question asks us, was the patient screened for shortness of breath? To answer the gateway question, you would review the hospice patient's clinical record, looking for documentation about a screening for shortness of breath. Based on what you see in the clinical record, you would answer either yes or no to the gateway question. So we refer to this as the gateway question because you can really think of it as being the gatekeeper to the latter parts of the item, parts B and C. If you answer yes to the gateway question, you're going to continue on to parts B and C. However, if you answer no to the gateway question, then you're going to kind of imagine this gate staying shut and you're going to skip parts B and C of the item. And if we kind of take a moment and think about this in a logical sense, parts B and C are asking you for the date of the screening and what the results were. And if you had answered no to the gateway question to indicate that a screening did not take place, you wouldn't be able to fill in a date or any results because there was no screen. So let's just say, for example's sake, that we've reviewed the clinical record, we find evidence that the patient was screened, we answer yes to the gateway question. So since we answered yes, we can now continue on to part B, which is the date component. And the date component is going to tell us when the care process took place. So we would go back to the clinical record where we found the documentation about screening for shortness of breath, and we would fill in here in part B the date on which that screening occurred. The last part of this item is part C, which is what we call the results component. And the results component is going to tell you what the outcome of the care process was. So for screening for shortness of breath, the result we're concerned about is what did the screening reveal? Did it show that the patient had shortness of breath, or did it show that the patient did not have shortness of breath? So again, you would go back to the clinical record, reviewing the documentation, and you would answer either yes or no to this results component. And it's important to note here that not all care process items have a results component. Typically, results will appear on care process items where the results of the first care process inform subsequent care processes. So in the case of a screening for shortness of breath, the results of that screen, whether the screen was positive or not, is going to inform whether or not you treat the patient for shortness of breath. And I want to look now at an example care process item that does not have a results component. Here on slide 40, we see item F3000, which is the spiritual and existential concerns item. You'll see this item just has two parts, parts A and B, and hopefully now these should look familiar to you as the gateway question and our date component. So for this item F3000, the gateway question is going to ask us, was the patient and or caregiver asked about spiritual or existential concerns? That's part A. Part B again is our date component, and we would fill in the date that the patient or caregiver was first asked about spiritual or existential concerns. So all of the care process items in the hospice item set will follow the same structure, with part A being the gateway question and part B being the date. But you'll notice here for this item that there is no part C. There is no results component. And in these instances, the results of the care process are not used in the quality measure calculation, and since they're not used in the quality measure calculation, they haven't been included in the hospice item set. So now that we understand the basic structure of the care process items, I want to go over how to complete the care process items in Section J, Respiratory Status. This section begins on page 2J10 of the Hospice Item Set Manual if you'd like to turn to that page now and follow along. So if we look at page 2J10, I want to take a moment and just kind of explain what sort of information is included in the manual for each care process item. Because the more you can familiarize yourself with what's in the manual now, the easier it will be as you're implementing the hospice item set. Up at the top of page 2J10, we see the section Rationale. This will appear at the beginning of each section, but not at the beginning of each item. So the section Rationale explains why a care process is important and how it can improve patient care. Underneath that on page 2J10, we have the item display. And this is just a screenshot of the item exactly as it appears in the hospice item set. On the bottom of page 2J10, we see the item-specific instructions. And these will outline the proper method for completing each item and will include explanations of all response options for each item. Turning now to page 2J11, we have the item-specific tips. And these will state clarifications, issues of note, and conditions to be considered when completing hospice item set items. Finally, at the bottom of page 2J11, we have examples, and examples will appear for most of the care process items, but not for all of them. Examples illustrate appropriate item completion based on sample clinical record documentation. The Hospice Item Set Manual provides examples to assist hospices in understanding the rationale for how to select the most accurate responses when completing the hospice item set. These examples are not intended to dictate or endorse languages hospice may use in clinical record documentation. Direct quotes that appear in examples are for illustration purposes only and do not represent CMS endorsement of specific documentation language or products. So now we can look at the rationale for Section J, respiratory status. Turning back to page 2J10 in the Hospice Item Set Manual, we will see here the rationale for this section. So respiratory status, or more specifically, shortness of breath or dyspnea, is an important part of symptom management. Shortness of breath can be functionally limiting and distressing to patients and their families. The two care processes that are covered in this section are screening and treatment for shortness of breath. Screening is important for determining the presence or absence of the symptom. If a patient is found to be short of breath, screening will also determine the severity. Screening for shortness of breath will also inform treatment options. Treatment for shortness of breath will vary with severity, etiology, and patient preferences. Treatment can also include pharmacologic and non-pharmacologic interventions. So here on slide 43, you'll see a table. And what we really wanted to do at the beginning of each section with this table is just kind of map out for you how the different items in each section relate to quality measure calculation, because that is the purpose of the hospice item set, is to have the data to calculate these quality measures. So our first care process in the respiratory status section is shortness of breath screening. And the relevant item for screening for shortness of breath is J2030. Item J2030, in turn, will be used to calculate NQF number 1639, which is the screening for shortness of breath quality measure. Our second care process in this section is shortness of breath or dyspnea treatment. The relevant item here is J2040, and this item will be used to calculate NQF number 1638, the dyspnea treatment quality measure. Let's take a closer look now at both of these quality measures. NQF number 1639 measures the percentage of patients screened for dyspnea during the initial assessment. NQF number 1638 measures the percentage of patients who screened positive for dyspnea who also received treatment within 1 day of the screening. And more information about both of these measures is presented in Appendix C. It's important to note about these two shortness of breath measures that they are what we call paired measures. So this means that the dyspnea treatment measure looks at types of treatment received only by patients who screened positive for shortness of breath in the previous quality measure. So in practical terms, as you're completing the hospice item set, if a patient did not screen positive for shortness of breath, you will not complete the dyspnea treatment item. Now we'll look at item-specific completion instructions, special tips, and examples for each dyspnea item, starting with item J2030, the screening for shortness of breath item. This item can be found on page 2J10 in the Hospice Item Set Manual. For item J2030, you are looking for evidence regarding screening for shortness of breath. J2030A asks, was the patient screened for shortness of breath? Hopefully you now recognize this as the gateway question. Providers should review the clinical record to see if there is evidence that a screening for shortness of breath took place. Based on evidence found in the clinical record, answer yes or no to indicate whether a screening took place. So remember here, if you answer no to the gateway question, which is this question here in J2030A, you will skip over parts B and C of this item and move on to the next item as indicated by the skip pattern, which in this case is item N0500, the scheduled opioid item. J2030B is the date of the first screening for shortness of breath. If you answered yes to J2030A, record the date of the first screening here. J2030C is the results component and asks, did the screening indicate the patient had shortness of breath? Based on evidence in the clinical record, record whether or not the patient screened positive for shortness of breath. For J2030C, if you answer yes, you will continue on to the treatment for shortness of breath item. And remember, this is how the fact that these two measures are paired plays into the completion of the hospice item set. So you will only move on to the treatment for shortness of breath item if you answer yes here in J2030C. If you answer no, you will skip that treatment item and you will move on to item N0500, the scheduled opioid item. Let's look now at some tips for this item. Tips for item J2030 are on page 2J11 of the Hospice Item Set Manual. The first tip states that structured evaluation for shortness of breath is not well defined. Unlike pain, for example, documentation in the clinical record regarding shortness of breath screening may not include the use of a standardized tool to evaluate presence or absence and/or severity of the symptom. So this means that if the clinical record shows the patient had shortness of breath, the severity does not have to be rated using a standardized tool in order to answer one yes for J2030A. The second tip states that evidence of a positive screen should consider both clinical signs of shortness of breath as well as patient and family report of the symptom. We're going to look now at some examples that will hopefully further illustrate kind of how you will use these tips in completing the item J2030. So our first example is situation A, and it appears on page 2J11 in the manual. In situation A, the patient's clinical record shows that the patient was very drowsy and appeared to be comfortable during the visit. And I want to pause now for a moment and feel free to kind of think it over to yourself or discuss with your neighbor. Given the evidence that was just presented in situation A, how would you complete item J2030? Do you think that the evidence here constitutes a screening for shortness of breath? Okay, I see some people already shaking their head no, but I'll give you guys just a couple of minutes to think it over and we'll reconvene in just a second. All right, so the person right there who shook your head no, you are correct. In this situation, the correct course of action is to code no to J2030A to indicate that the patient was not screened for shortness of breath. Since you answered no to J2030A, which is our gateway question, you would then skip parts B and C of the item and move on to item N0500. So why did we say that the patient was not screened for shortness of breath in this situation? Let's think back about the documentation we found in the clinical record for situation A. All we found was documentation stating that the patient was drowsy and appeared to be comfortable during the visit. In this situation, the clinical record contains no evidence that shortness of breath was evaluated as a specific symptom. So although screening for shortness of breath is not well defined and as such does not require the use of a standardized tool for evaluation of the symptom, in order to answer yes to J2030A, there must be evidence in the clinical record that the clinician evaluated shortness of breath specifically. Our second example is situation B, which appears on page 2J12. In this example, the clinical record shows that on August 12, 2014, the patient was breathing shallowly but reported no discomfort, and there were no concerns from the patient or the family. So take a minute now and think or discuss amongst yourselves, how does situation B compare to situation A? And what do you think the correct responses are in this situation for item J2030? In this situation, the correct course of action is to code 1 yes for J2030A to indicate the patient was screened for shortness of breath. You would enter August 12, 2014 for the date, and you would select code 0 no for J2030C to indicate the patient was not short of breath. Again, let's think back on the clinical record documentation and consider why we answered yes to J2030A. In situation B, the documentation is specific to shortness of breath, and the clinical record clearly shows the clinician evaluated for shortness of breath as a specific symptom. Remember, for the results of the screen, which you will note in J2030C, when determining whether or not the patient had shortness of breath, you should consider both clinical observation and patient and family report. In this example, although the clinician observed the patient breathing shallowly, neither the patient nor the family stated any discomfort or concerns. So this means that the best course of action is to answer no for J2030C to indicate the patient did not have shortness of breath. Our last two examples for this item are situations C and D, and they are on page 2J12 in the Hospice Item Set Manual. In situation C, the patient's clinical record shows that on August 12, 2014, the patient reported breathing difficulty when walking, and that breathing was eased after resting or using oxygen when active. In this situation, the correct course of action is to code 1 yes for J2030A to indicate the patient was screened for shortness of breath. Enter August 12, 2014 for the date, and select code 1 yes for J2030C to indicate that yes, the patient did have shortness of breath. In situation D on page 2J12, the clinical record shows that the patient was nonverbal. On August 12, 2014, clinical observation showed a respiratory rate of 28 with intermittent use of abdominal breathing and some wheezing, but good air movement. In this situation, the correct course of action is to code 1 yes for J2030A to indicate that the patient was screened for shortness of breath. Enter August 12, 2014 for the date, and select code 1 yes for J2030C to indicate that yes, the patient did have shortness of breath. So again, I want to take a moment and just review our coding for both of these situations and consider why we completed J2030 the way we did. In both situations, C and D, the clinical record clearly shows that the patient was evaluated for shortness of breath as a specific symptom. So this means that you can answer yes to J2030A and continue on to parts B and C. In both situations, the clinical record shows that the patient was short of breath, whether based on self-report or clinical observation. The next item in the respiratory status section is item J2040, treatment for shortness of breath or dyspnea. Item J2040 is used to calculate NQF number 1638, the dyspnea treatment quality measure. If you look now at page 2J13 in the Hospice Item Set Manual, you will see the item-specific instructions for J2040. For this item, you are looking for evidence in the clinical record pertaining to treatments for shortness of breath. J2040A asks, was treatment for shortness of breath initiated? So remember, the two shortness of breath quality measures, NQF number 1639 and 1638, are paired. So this means you will only complete this dyspnea treatment item if the patient screened positive for shortness of breath in part C of the previous item. So if the patient did screen positive for shortness of breath, for J2040A, you should review the clinical record to see if there is evidence that treatment for shortness of breath was initiated. Based on evidence found in the clinical record, answer 0, no, 1, no, patient declined treatment, or 2, yes, to J2040A. So you'll notice here that J2040A, that there are two no response options, and this is a little different from the other item that we've looked at. So you should use the option 0, no, if treatment for shortness of breath was not offered. Let me repeat that. You should use 0, no, if treatment for shortness of breath was not offered to the patient. You should use 1, no, patient declined treatment, if the hospice offers treatment to the patient, but the patient declines. And this second option, the one no patient decline treatment, allows for the incorporation of patient preferences. There could be an instance where a clinician observes clinical signs of shortness of breath and offers treatment, but the patient declines because they have acclimated to the symptom and are not uncomfortable, even though they may be exhibiting clinical signs of shortness of breath. So if you use either of these no response options, either the 0 no or the 1 no for J2040A, then you will skip J2040B and C, and you will move on to item N0500, the scheduled opioid item. For J2040B, you will list the date treatment for shortness of breath was initiated. Treatment initiation is defined as the date that an order was received to either initiate or to continue a treatment. An order may be verbal or written, and you should complete J2040B based on whichever was used to determine the start of treatment. For non-medication interventions, such as fans, positioning, or patient education, there will not be any orders in the clinical record. In this case, you would enter the date that the intervention was delivered for J2040B. The final part of this item is J2040C, and this is where you will list the types of treatment for shortness of breath that were initiated. For J2040C, you should check all that apply to indicate which types of treatment were initiated. You will check 1, opioids, if the patient received opioids for shortness of breath. You will check 2, other medication, if a non-opioid medication was initiated. You should check 3, oxygen, if the patient received oxygen. And you should check 4, non-medication, if the patient received a non-medication intervention for shortness of breath other than oxygen. Examples of non-medication interventions would include fans, positioning, and education about energy conservation techniques. Let's look now at some tips for this item. Tips for item J2040 are found on page 2J14 in the Hospice Item Set Manual. For item J2040, you should include both regularly scheduled and PRN treatments. You should include standing orders only if they are initiated. And this last tip here on the slide talks about treatments that have multiple uses. So, for example, opioids can be used to treat either shortness of breath or pain, and relaxation techniques can be used to ease either shortness of breath or anxiety. For treatments that have multiple uses, the clinical record must indicate that the treatment was initiated for shortness of breath in order to include it in item J2040. Let's look now at an example that'll further explain this tip. If you turn over to page 2J15 in the Hospice Item Set Manual, we see our first example, which is presented in situation A. In this example, the clinical record shows that the patient was short of breath. Evidence regarding treatment initiation shows that the clinician instructed the patient and family on energy conservation techniques on August 12, 2014. There is also an order for morphine, which is dated August 12, 2014. So take a moment now and review the clinical record documentation for situation A, thinking about how you would complete item J2040 in this situation. So for situation A, the correct course of action is to code 2-yes for J2040A, since treatment for shortness of breath was initiated. You would enter August 12th, 2014 for the date, and you would check for non-medication as the type of treatment initiated in J2040C. So again, let's review situation A and our coding choices. Situation A presented 2 treatments, but we only listed 1 in J2040C. Why? Situation A stated that 2 treatments were initiated on August 12, 2014. Instruction about energy conservation techniques and morphine. Taking a closer look, we notice that one of these treatments has multiple uses, morphine. Morphine is an opioid that can be used to treat multiple symptoms such as pain and shortness of breath. In the Situation A example, the clinical record documentation only shows that there is an order for morphine. The order does not include an indication. As such, we do not know why the morphine was initiated. Was it initiated for pain or for shortness of breath? Based on the clinical record documentation presented here, we simply cannot know, so we cannot list the morphine as an opioid treatment in J2040C. Taking this example one step further, what would an order for morphine need to look like in order to include it in J2040C? To be included as a treatment for shortness of breath, the order list would need to include an indication, such as morphine 2 to 15 milligrams IV every 4 hours as needed for shortness of breath. Our second example for item J2040 is situation B, and it is also on page 2J15 in the Hospice item set manual. In situation B, the clinical record shows that the patient was short of breath and that treatment was initiated. On September 15, 2014, the clinician instructed the patient and family to keep the patient's head elevated. An order dated September 16, 2014, also shows that oxygen was ordered along with scopolamine to dry respiratory secretions. What about this particular situation? How would you complete item J2040? Take a moment and think about it, and we'll go over it in just a second. For situation B, the correct course of action is to code 2-yes for J2040A, indicating that treatment for shortness of breath was initiated. Enter September 15, 2014 for the date, and check 2 other medication, 3 oxygen, and 4 non-medication for J2040C, the types of treatment for shortness of breath that were initiated. In situation B, documentation in the clinical record clearly shows that 3 separate treatments for shortness of breath were initiated on 2 different days. Clinical instruction on September 15th and oxygen and scopolamine on September 16th. All 3 treatments are listed in J2040C, but what is the proper date to use for J2040B? The date the first treatment for shortness of breath was initiated is the proper date to list in J2040B. Looking back at the clinical record documentation, we see that September 15th, 2014 is the proper date to list since the educational component was delivered first. So to summarize, for item J2040, you're going to include all of the treatments in Part C, but use the date of the first treatment in Part B. So this actually concludes our section for respiratory status. And we know that we've covered a lot here, and we're sure that you all have questions about this section. So again, if you want to just, for those of you that are in the room, if you want to write your questions down on your index card, if you can please make sure to put the item number and either a slide number or a page number from the manual, that would help us out. And also make sure to include your email address, because if we do not answer your question, then that's how the help desk is going to get in contact with you. So I think that the questions for shortness of breath are going to be addressed in tomorrow's Q&A, along with the questions that you'll have for pain and for medications. So we will be answering those tomorrow. So that means for those of you that are live streaming, if you can wait until tomorrow to email your shortness of breath questions to the help desk, that would help us just avoid unnecessary traffic on the help desk and will speed up response time for everyone. So I'm going to turn it back over to Kim, who's going to give a few concluding comments for today.
Thank you, Alexis. Okay, so what I'd like to ask you to do for the live stream viewers, if you have a question and it was not answered today on any of the information except for dyspnea, please feel free to send that question in to the quality desk, and we'll get an answer to you on that. Now, the other thing that I'd like to let the audience here in person know about, and the live streaming people, is that there's some type of winter weather situation that we may get tomorrow. Of course, we don't know for sure one way or the other, but the best thing to do would be to call the number that I'm going to give you so that you can find out if we're opening on time, if there's a delayed opening, so that you can plan your day. So to check for CMS closure or a late arrival, please call 786-6010. I'll repeat that. 410-786-6010, or I'll give you a 1-800 number. That's 1-800-448-4232. That's 1-800-448-4232. If it seems like there's, a weather issue going on, call that number, and that recording will tell you whether we'll open late or not open, or hours are as, normal business hours. So whatever you hear, we'll take the worst example first. If CMS is closed tomorrow, then day 2 would be presented in late March, early April. If CMS opens late tomorrow, but before 12:30, just arrive as you did today. We'll have the training at 12:30 tomorrow. The other scenario is if CMS opens late tomorrow, but after 12:30, still please come and we'll get started as soon after 12:30 as we can. We'll shoot for 12:30 to get started. With the smaller amount of people in the audience, it's easier to get started. We had factored in many more than are here in person, so we'll be fine. So I'll repeat the numbers one more time. To check for CMS closure or late arrival, call 410-786-6010 or 1-800-448-4232. So we've covered a lot of information today, and we'll continue back again tomorrow at 12:30. If you haven't had the opportunity to take a look at the manual, If you could do that tonight, that would make tomorrow so much more valuable for you. And we really appreciate your attention and the good questions that were submitted, and we look forward to working with you again tomorrow. So thank you and safe travels.